The antiglobulin test. So anti-human globulins, or AHG, they are reagents used in immunohematology to detect non-agglutinating antibodies or complement bound to red blood cells. They bind to human globulins such as IgG or complement components like C3 that are either free in the serum or attached to red blood cell antigens. Source of anti-human globulins. So these are derived from animals, usually rabbits or goats, that have been immunized with human globulin components. Anti-human globulins may be polyclonal or monoclonal. Detectable immunoglobulins, we have IgM antibodies. These are usually large and can agglutinate red blood cells directly at room temperature or below. IgG antibodies are smaller and do not cause direct agglutination. They are incomplete antibodies. Anti-human globulins are needed to bridge these antibodies and cause visible agglutination. So types of anti-human globulin reagents, we have anti-IgG, which detects the IgG bound to red blood cells, anti-C3, which detects complement coating on red blood cells, and polyspecific AHG, which detects both IgG and complement components. So before the anti-human globulin test, only IgM antibodies could be detected reliably using routine agglutination techniques. These antibodies are pentameric and can cross-link red cells easily, producing visible clumping at room temperature or colder. So the problem with IgG antibodies is IgG antibodies are monomeric and are much smaller. They typically do not cause visible agglutination because their structure doesn't span enough distance to bridge between red blood cells. So they are called incomplete antibodies. So in 1945 to 1946, the anti-human globulin test, developed by Robin Coombs, along with the Morant and Race, was a major milestone in transfusion medicine. It allowed for the detection of IgG antibodies bound to red blood cells even when there was no visible agglutination. The initial use was for Rh antibodies, so the test was used first to detect anti-D antibodies in Rh-negative mothers carrying Rh-positive babies, which was a critical advancement to help understand and manage hemolytic disease of the fetus and newborn. The anti-human globulin test is also known as the Coombs test. It is critical in identifying sensitization of the red blood cells that is not visible through direct agglutination. It detects the presence of antibodies or complement bound to the surface of red blood cells, which may otherwise go unnoticed, as mentioned before. The anti-human globulin test may be used to detect red blood cells sensitized with IgG alloantibodies. So these are antibodies produced against antigens that are not naturally present on a person's own red blood cell, or commonly formed after transfusions, pregnancy, or organ transplants. Can be associated with blood group systems like Rh, Kell, Duffy, and KID. Can be detected via the indirect antiglobulin test in antibody screening or cross-matching. IgG autoantibodies, so these are self-reactive antibodies that mistakenly bind to one's own red blood cell, seen in conditions like autoimmune hemolytic anemia, and these can be detected using the direct antiglobulin test, or DAT, which looks for antibodies already bound to the red blood cells in the patient's body. The complement components, so especially C3 components, which may be activated by either IgG or IgM antibodies. Complement may remain attached to the red blood cell membranes after antibody binding and activation. This is important in both immune hemolysis and some cold agglutinin diseases. These can also be detected via the DAT, particularly with an anti-C3 reagent. So the anti-human globulin test is used to detect antibodies or complement proteins bound to red blood cells, as mentioned earlier, but it comes in two main forms. So we have a direct and indirect. So the direct antiglobulin test, or a DAT, is in vivo sensitization. Its purpose is to detect antibodies or complement that is already bound to red blood cells inside the body. We use this in times where we are suspecting autoimmune hemolytic anemia, hemolytic disease of the fetus and newborn, transfusion reactions, and drug-induced hemolysis. Indirect antiglobulin test, or IAT, is an in vitro sensitization. Its purpose is to detect antibodies in serum that could bind to red blood cells outside the body, or in vitro. This is a two-step process for the procedure. So you would incubate the patient's serum with red blood cells, which is the sensitization stage, and then we're going to add that AHG, or anti-hemoglobulin reagent, to help detect that binding. We would use an indirect antiglobulin test for antibody screening identification during cross-matching and during red blood cell phenotyping. There are different types of antihemoglobulin reagents. So we have polyspecific antihemoglobulin, and that contains antibodies against both the human IgG and the C3d component of the complement. We would use this in the initial screening to detect a broad range of sensitizations for IgG or complement. And then we have the monospecific antihemoglobulin reagent, and this contains only one type of antibody, so either IgG or anti-complement. We would use this to differentiate between IgG and complement coding on the red blood cells when a more specific interpretation is needed. For preparation of antihemoglobulin, so how they make it, basically, we have polyclonal. It is produced by injecting human globulins into animals, which were usually rabbits. It results in antibodies that react with multiple epitopes, which increases sensitivity. This is cheaper and easier to produce in large quantities, and it naturally contains a broader spectrum of antibody activity. Some disadvantages of this is we have batch-to-batch variability due to the animals having biological variability in themselves, may have nonspecific reactivity or cross-reactivity, could lower specificity compared to monoclonal antibodies, and there's a risk of contamination with non-human proteins, which could potentially affect results or cause reactions. So preparation of the monoclonal antihemoglobulin, some advantages is it's highly specific, so it binds to a single epitope. It's consistent performance, so there is no batch-to-batch variability. It's reduced background noise, so there's minimal cross-reactivity. It can be produced in large quantities using a hybridoma technology, and it usually has a pretty long shelf life and stability. Some disadvantages: it's expensive and time-consuming to produce initially. It could lack reactivity with some antigen variants due to narrow specificity, and it has limited sensitivity compared to polyclonal antibodies in detecting multiple epitopes, and it also requires advanced technical expertise and facilities. Anti-IgG activity must be present for effective detection of sensitized red blood cells. So antihemoglobulin reagents should include a mixture of IgG1 and IgG3 subclasses. These are the most clinically significant IgG subclasses in blood group immunology. Other non-agglutinating antibodies could exist but are rarely encountered. So the most clinically significant antibodies are IgG. These include antibodies that can cause hemolytic transfusion reactions or hemolytic disease of the fetus and newborn. So there's an ongoing debate regarding the advantages and disadvantages of different testing and reagent approaches. So polyclonal versus monoclonal, which better? It just kind of depends on what you're looking for and what lab you're working in. So the direct antiglobulin test, or the DAT, its purpose, as mentioned earlier, is to detect in vivo coding of red blood cells with IgG antibodies and complement components. Applications: we can use this, as mentioned before, as a hemolytic disease of the newborn, hemolytic transfusion reactions, autoimmune hemolytic anemia. Sample requirements: so blood should be collected in a tube that contains the EDTA as an anticoagulant. And this helps to prevent an in vitro complement activation, which ensures accurate DAT results. This is a nice little picture that kind of shows you what happens during the DAT test. And this is a video that you would want to watch on how to actually perform the DAT or Coombs test. So when you are evaluating a positive DAT, you're going to refer to the AABB technical manual, and there are sections on DAT and evaluation, so each lab is going to have a reference on what to do and what you need to do further. So the purpose is it's going to guide the need for further testing based on different clinical states where the DAT is positive. Some points to make: so positive DAT requires clinical correlation to determine significance. Further testing helps to differentiate those causes, like if it's hemolytic disease of the newborn, is it autoimmune, what's actually causing it. So make sure you watch this video down below so you know how to run it. For an indirect antiglobulin test, its purpose, as mentioned before, is to detect an in vitro sensitization of red blood cells, so those red blood cells that are coated with antibodies in the lab. We would use this for compatibility testing, red blood cell phenotyping, and titration of incomplete antibodies. Factors that can affect the antiglobulin test is temperature. So sensitization best occurs at body temp, so 37 degrees Celsius. Incubation time has to be sufficient for the antibodies to have time to bind to those red blood cells. You want your pH to be at that optimal level is 6.5 to 7.5. Ionic strength, you want it to decrease in ionic strength can enhance agglutination. Serum to cell ratio, the recommendation is a 2-to-1 ratio. Washing of red blood cells, so it's essential to remove those unbound antibodies and serum proteins. Type of antihemoglobulin reagent, so for using, polyspecific or monospecific, IgG or complement, what are we looking for? And also your red blood cell suspensions need to be a 2 to 5% suspension, which is the most commonly used. Most common sources of error in the antihemoglobulin test is inadequate washing of the red cells, non-reactive antihemoglobulin reagent, or failure to add the antihemoglobulin reagent to your process. So this says a note, all negative antihemoglobulin test reactions must be checked by the addition of an IgG sensitized cell, also known as check cells or Coombs control cells, and this helps to ensure that the antihemoglobulin reagent was active and the test was actually performed correctly. For comparison of antihemoglobulin methodologies, so the goal is to detect any and all clinical significant antibodies, both the direct and indirect types, and none of the clinically insignificant antibodies, such as warm and cold reacting autoantibodies.